Hi there. This is Jason Starr coming to you from Jacksonville, Florida. I'm a medical oncologist over at Mayo Clinic, specializing in neuroendocrine cancers with a passion for helping patients in need with this disease. Anytime we start a treatment, I'm very judicious and I come up with a scale here to exemplify that. In terms of when to start a therapy, is the timing right? There's a lot of nuance with selecting time of therapy, but once the shared decision making between the patient and the oncologist is, you come to the point where you say, okay, we need to start a new therapy. You have to balance the efficacy and the side effects. And side effects go in with quality of life, right? If you're on a therapy, you want to be living your best life and you want that therapy to work. I would say when the scale gets tipped in terms of the balance of the side effects becoming so great, the efficacy becomes maybe even less relevant, right? Because if day to day it's a struggle, but the therapy's working, at some point you may ask yourself, is this worth it to me, right? And that's a very individualistic decision. So one of the rules of thumb that I have is always err on holding the medication, in that you're going into the weekend, it's a Friday, you're waiting for a call back from the medical team, and you're experiencing significant side effects, diarrhea, fatigue, or skin rash, anything obviously that needs urgent evaluation. You want to consider going to the emergency department or an acute care clinic if the medical facility has that. But holding the medication is always the best strategy, in that the faster the drug kind of gets out of the system, the faster the side effects resolve. And it's not going to be detrimental to your overall treatment to hold the medication for a short period of time. And then maintaining that active dialogue with the medical team. Hopefully the medical team has a system in place where you're experiencing side effects, they're doing a check-in a few days later, they're bringing you in, they're checking the lab that may be in question. So it's just a matter of having that two-way dialogue going on with your medical team so that they know how you're doing and you can express yourself in terms of any concerns that you have. So many offices, we have at Mayo Clinic, have an acute care clinic where the providers may not have opening on their schedule or calendar for that day, but you can come in and be seen, usually an advanced practice provider, an APP, for evaluation, IV fluids, determination of how the severity of whatever side effect that you're experiencing. And one thing that I really stress to my patients is one dose does not fit all. So along the way, you may require a dose reduction, and that's dialogue that you can have with your provider. So we're going to review potential side effects of somatostatin analogs, which are probably the most commonly used medications in neuroendocrine tumors. We're going to talk about lutetium 177 dotatate, or Lutathera. We refer that class of medication as PRRT, peptide receptor radionuclide therapy. And to complicate things, some people now refer to it as RLT, radionuclide labeled therapy, both the same thing. Everolimus or Afinitor, capecitabine or temozolomide, which we refer to as CapTEM, and then tyrosine kinase inhibitors, sunitinib, which is the old school one, maybe 2011 got FDA approved, and then cabozantinib or Cabometyx is a medication that was approved last year, which is also a tyrosine kinase inhibitor. So somatostatin analogs. And you'll see there's a lot of potential side effects. And that's why, although it's a synthetic hormone that your body makes naturally, there's side effects, right? So even though it may be like, oh, we're going to start a hormone therapy, it's an injection once a month, it doesn't come without potential side effects. Some patients have diarrhea for a day or so after injection. And that could be ironic in the fact that sometimes we are using the medication to treat diarrhea, whether it's related to carcinoid syndrome. But sometimes that diarrhea can briefly worsen. A lot of times for patients with carcinoid syndrome, they actually notice pretty rapid improvement. Usually the diarrhea that I see is in patients without carcinoid syndrome. Nausea and vomiting. This medication kind of slows everything down, right? It's an inhibitory hormone. It slows the digestive system down. So sometimes it will delay stomach motility or stomach movement. Similar to how the GLP-1 agonists, those new drugs that we use for weight loss work. So that can lead to nausea and or vomiting. And then exocrine pancreatic insufficiency, EPI. This is really common. Actually, Dr. Lowell Anthony, who's one of the godfathers of neuroendocrine tumors, told me once upon a time that patients, by definition, develop exocrine pancreatic insufficiency when they're on these medications. That's how you know that you're on a therapeutic dose. And again, the drug makes things lazy. It makes the pancreas lazy. It doesn't damage the pancreas, but it makes it lazy. And why do you need your pancreas? Well, there's a hormone side to it, right? Regulate your blood sugars, for example, insulin, another hormone called glucagon that helps regulate your blood sugars. But then there's the other component of the pancreas that helps with the digestion, and more specifically, fat digestion. So if you eat a fatty meal, you need your pancreas. It makes an enzyme called lipase to help you digest your food. When you're on these medications, you will get a lazy pancreas. A good majority of my patients are on pancreatic enzyme replacement. And there's over-the-counter pancreatic enzymes, and then there's prescription strength ones. So you should talk to your doctor if after you eat a meal, you get bloating, gas, just don't feel right, especially after a fatty meal, you have exocrine pancreas insufficiency. I don't do any fancy testing to make this diagnosis. For me, it's a clinical diagnosis while on these medications. Blood sugar fluctuations, as we said, the other component of the pancreas is the endocrine side. I see some high blood sugars more common than low blood sugars, but I do have some patients who develop low blood sugars to the point where, they have to be careful and carry glucose tablets around with them. Gallbladder problems, again, it's a lazy hormone, so it slows the contraction of the gallbladder. This predisposes patients to gallstones and gallbladder issues. So you develop some pain in what we call the right upper quadrant, radiates to the back, worse after eating, it might be the gallbladder. Injection site pain. A lot of patients will describe little like knots or nodules at the sites where the injections are done. Those shouldn't really happen if the injections are being done right. So they should be thawing out the medication for the appropriate amount of time, not bunching up the skin when they're doing the injection. So you just want an experienced nurse doing the injections. But one thing to decrease the chances for injection site pain is to put a lidocaine patch on the area. So I prescribe those very often. You put it on before you go in, right where you're going to get the injection. The nurse will take off the patch and then go ahead and do the injection, and the area is numb. So it's a nice trick, and some of my patients really appreciate that. So less common side effects. I've seen some blood pressure changes, particularly increase. I've seen some patients develop joint discomfort. I've seen some low heart rates, so what you call bradycardia, which is a decreased heart rate. I've seen headaches. I've seen fatigue. I had one patient who had really debilitating depression after getting the injections. So you'll see at the end of the talk where one of my rules of thumb is that if you get a medication and you develop a side effect, it's the medication until proven otherwise, right? You can try to explain it away, but if you're putting something into your body and you develop a symptom, it's that something you put into your body. Lutathera, so that's that class of medications called PRRT or RLT. Now, Lutathera is the kid on the block that's been there for the longest. It got approved in January of 2018. There are some drugs very similar to Lutathera that are going to be coming available in the very near future. So that can be a discussion that you have with your oncologist. But these side effects are within this class, I would say, of therapies. So the Lutathera, as it is right now, is given once every 2 months as an IV infusion for 4 doses. Some patients do develop some nausea and or vomiting on the day of the infusion. This was a big problem before we were compounding the amino acids, so we were giving a less specific amino acid solution. This has been obviated and eliminated in terms of now that we use a compounded amino acid solution. We don't see that at all with that amino acid solution. So nausea is typically not an issue. We do give an anti-nausea medication just in case, as the actual Lutathera itself can cause nausea in percentage of patients. Diarrhea, some patients get that for a day or so after the treatment, usually very mild. Fatigue is the prevailing side effect that most patients experience. It can be present throughout the treatment. It can happen for a few days after the treatment, and it can actually persist for a few months beyond the treatment because we know that the therapy, once it kind of goes in there and does its thing, can continue to work. Although the drug is out of the system, the effect on the cells can still be going on. So patients can continue to have some side effects. So don't rule that out. Hair thinning is typical, but not loss. I haven't really seen hair loss, like complete hair loss, but thinning for sure. It can sometimes temporarily worsen carcinoid syndrome, particularly if a patient is having carcinoid syndrome and the symptoms are quite severe. That first dose can definitely trigger worsening of that carcinoid syndrome. So we utilize short-acting octreotide, which is a subcutaneous injection as a rescue medication. But remember, the day of your Lutathera, you also will get your long-acting somatostatin analog, whether it be lanreotide or octreotide LAR. Less common side effects that I've seen: joint discomfort. So I have patients use NSAIDs like ibuprofen, but sparingly. Kidney problems, typically in patients who have kidney issues, it can exacerbate pre-existing kidney issues. Infusion reaction. I did have one patient who developed anaphylaxis, which is like a severe allergic reaction with Lutathera. Very rare. I've treated over 100 patients with this therapy and seen it one time. Bone marrow suppression is the most common lab abnormality. So if you get your labs, you will notice maybe a low hemoglobin, which is consistent with anemia, which is your red blood cells. You may notice low white blood cells, and also most commonly low platelets. Platelets help clot your blood and clump up together to help you prevent bleeding. Usually the extent of the low platelets is very mild and not severe to precipitate bleeding. And there is a small but very real risk of leukemia. And the studies quote 2 to 3%. We think it might actually be a little bit higher than that, maybe not a lot higher than that, but that's what we've seen in the studies so far. That is absolutely something that needs to be discussed with your provider. So let's go to Everolimus or Afinitor, kind of a tried and true therapy, very effective for some patients. The FDA approved dose is 10 milligrams. My philosophy is start low and going up to the recommended dose. If we start at the recommended dose and you get severe side effects, you kind of get snake bitten in that I don't know if I want to go back on that. I felt so badly. So I always say, start on the lower side and bump it up accordingly over the course of a month or two. Always recommend starting a dexamethasone mouth rinse, which is a steroid mouth rinse. Fatigue unavoidable with this drug. Everybody that I think I've started on it has had some level of fatigue. Other things that it can cause: diarrhea, skin rash, leg swelling. I've had to stop the therapy in some cases for patients who have had such severe leg swelling. Cough or shortness of breath. This one's really important. I've seen quite a few patients develop really quite severe inflammation of the lungs. Now, if you intervene quickly, you can prevent it from getting serious. But as soon as you develop some shortness of breath or cough, even if it's mild, just let your provider know. They should be asking you about this every time. The other thing I didn't put on here that I should have is it can suppress your immune system. It affects what we call the T cells. The T cells are really important with your, fighting infections in your body. So I have seen some patients develop lung infections related to this drug because their immune system was suppressed. And then the other thing is it can lead to elevated blood sugars and or lipids, particularly triglycerides. So your physician should be keeping an eye on your blood sugar and your cholesterol panel. So let's go to CapTEM, which is capecitabine, one drug, and temozolomide or Temodar is the other drug. The drug schedule can be confusing. I recommend getting a calendar and mapping it out, because one of the drugs you take for 14 days, another drug you take for 5 days, but at the end of what we call the cycle, so days 10 through 14, it's given every 28 days. Getting a calendar and mapping it out is really important. Really also important is discussing with your provider the role of DPD testing. So what this is an enzyme in your liver that metabolizes the drug called capecitabine or Xeloda. Some patients are slow metabolizers, and if you metabolize the drug slowly, then the drug will become toxic in your body and would require a dose reduction. Now, my philosophy is I'd rather know that up front than know that in a reactive. So I like to be, proactive instead of reactive. So a proactive approach is to do this test, know the results, and get a dose appropriate for your body. So I would strongly advocate for this, and the FDA has put labels on the drug to also recommend this. Side effects for the capecitabine: fatigue, diarrhea. There's a rash that can develop on the palms of the hands and the soles of the feet. A drug which is an anti-inflammatory called diclofenac. It's also brand name Voltaren. It's actually over the counter now. You can use this twice a day on those areas, and it can help prevent that rash. So keep that in your back pocket if you're going to be on this therapy or you're already on the therapy. Mouth sores, joint discomfort, I have seen. Temozolomide, nausea. This is the big one that I need to really emphasize. Please take your anti-nausea medication at least 30 minutes prior to taking your temozolomide. Otherwise, almost certainly you will develop nausea and probably vomiting. My patients will tell me, I forgot it once and I'll never forget it again, because it's miserable to feel nauseous and vomit while taking these therapies, at any time. Bone marrow suppression, so that's a really important one. So I have patients check their labs every 2 weeks for the first 2 months just to make sure that the blood counts are appropriate, and then we kind of go to a monthly schedule after that. But you really have to watch your blood counts. I've seen some really severe low blood counts, and we're not able to predict which patients will develop that. So lastly, we're going to talk about tyrosine kinase inhibitors. So those two drugs are cabozantinib and sunitinib. We talked about at the top of this talk that one is the new school one, one's the old school one. Both are acceptable for prescribing and for treatment. The cabozantinib, the majority of patients on that trial, 60% or so, had to have their dose lowered from 60 milligrams to 40 milligrams. So my philosophy, start low, go slow. I start at 40 milligrams and see how patients tolerate that for, at least 2 to 4 weeks before ramping it up to 60 milligrams. I will say it can be misleading. Being on a pill is convenient for sure, but the side effects can be more than IV treat. So I think that collectively, between the physician and you and the shared decision making, it should be understood that these are real treatments, even though they come in pill form, and they need to be treated as such. Fatigue can be quite severe. I said kind of unavoidable on that end. Nausea, we can see in a certain amount of patients, so we just watch for that. Sometimes, again, you can take an anti-nausea medication before your therapy, and that's a fine strategy. Ondansetron is probably the most commonly used. Just be careful with constipation with that drug, but there's no issue with taking that before your therapy. Diarrhea, usually very easily managed with antidiarrheals such as Imodium or Lomotil is prescription strength. So usually if the Imodium isn't doing the trick, we'll prescribe Lomotil. Elevated blood pressure, very common and easily managed by your primary care physician or your oncology team. The impaired wound healing is important to point out, because if you're going to be undergoing a surgery or a procedure even, you need to talk to your oncology team about holding that drug before that planned surgery or procedure, because even after, while the wound healing is occurring, you don't want to start the medication too soon. I have seen some bad outcomes in terms of wound healing issues after a surgery. There is a risk of bleeding and or clotting. This drug does affect blood vessel formation. So that's why you see some of these side effects in terms of blood pressure issues or bleeding and or clotting. The risk of bleeding and or clotting is low, but it is something that needs to be discussed. And if you have signs or symptoms, say you had swelling in your leg, it was painful, we would need to evaluate, make sure you don't have a blood clot in your leg, for example. You can develop a rash on your palms of your hands and soles of your feet, similar that we talked about the capecitabine. And similarly, with the diclofenac gel, we can use that to help prevent this. So that's a nice trick that is really a proactive, as we talked about being proactive as opposed to reactive. Liver inflammation, quite common, and we usually just pick this up on blood tests. Usually you won't feel anything as it relates to this. So your blood tests will be monitored regularly, just like you would be on any other medication. And something that may be under-recognized is thyroid issues. This class of medications can affect the thyroid gland and make it kind of sluggish or lazy. So that needs to be monitored probably every 3 months or so by either your primary care physician or your oncology care team. So the take-home points are these. Early recognition of side effects leads to quicker resolution of symptoms. When in doubt, call your team, let them know what you're experiencing, and then again, don't hesitate to hold the drug. Aggressive management of the side effects will allow you to stay on the therapy longer. So having that dialogue with your team, and again, even though it's a pill, you may need to be seen once a week or once every other week to help tailor and manage these symptoms to get it right. Remember, one size does not fit all in terms of the dose. So dose adjustments are very common. Please don't take that as, oh, the drug isn't going to work now. We have to find the right dose that works with your body. And then please also let the team know about any supplements you may be taking so we could determine if any of those could be contributing to the symptoms. There's a lot of potential what we call drug-drug interactions. So we just have to know what you're taking. We're not going to judge. A lot of patients ask me about ivermectin or febendazole or mebendazole. I'm not going to judge, but we just need to know what you're taking. And then my rule of thumb. It is always the medication accounting for new symptoms that may appear while on the drug until proven otherwise. You take the drug, you get symptoms, it's the drug until we prove it otherwise. Thank you very much, and I hope you all enjoyed and had some things to talk to your physicians, help create a dialogue, and it was a pleasure being here, albeit virtually.